Yeah, might scare a few people.
Good evening, ladies and gentlemen.
Good evening. Good evening.
Welcome to the Health and Wellbeing Committee for Decorum Council. And as this is the new council year, we've got a change of chair. And I'd like to thank Kathy McCavery for the work she's done previously, and I'm now chairing this meeting. So, first of all, welcome to everyone. I'll take it through. I'm going to make a few changes to the running order of the agenda, but I'll cover those in a moment. So, first of all, can we discuss the minutes of the previous meeting? These have been circulated. Does anyone have any comments they wish to make about their accuracy? Hearing nothing, so I take it we're happy to approve that. Does anyone want to make comment? Yes or no? Everyone happy? Agreed, right. Thank you. Okay, moving on, apologies for absence. Can you take us through the people who have actually given apologies?
Yeah, that's fine. I've got Councillor Elliott, he's given his apologies, and so has Councillor Hemel. I've got Councillor Guest substitute for Councillor Elliott, and Councillor Greenfield substitute for Councillor Hemel, and I've got apologies from C-Link.
Right, thank you for that. Are there any declarations of interest people have got?
I have a declaration of interest, although obviously I'm not on committee, I'm here as Mayor today.
Ex-officio, yeah.
And I do work for Hertfordshire Community and NHS Trust.
Okay, thank you. All right, now I propose to take items 8 and 9 next and then go through the running order of the agenda, basically on discussion with Toby, because it would work better, I think, for the running order of the meeting. So can I give you over to Toby to do the take this forward?
Thank you, and just, if you don't mind, Chair, just to reflect that conversation back, I think what we thought might be helpful is to give a bit of broader context on what's happening locally within the NHS, both with the ICB and with the Trust locally, before we then get into the nuts and bolts work locally on Hemel. So I hope you'll appreciate that. That's a useful context to have before we get into the weeds. On national context at the moment, you'll be aware that there were major announcements made in the last couple of months in relation to NHS England, which is due to be absorbed into the Department of Health, and in relation to integrated care boards, where there's been a ask that they cut their running costs by about 50%. That, as you can imagine, has triggered lots of work nationally and regionally and locally, and our system is no different on that. I would say that is likely to end up in an integrated care board that is operating over a wider geography than the one it currently operates over in Hertfordshire and West Essex, in order to meet that running costs reduction ask. And at the same time, we've been doing work now for a couple of years in developing what we call our place partnership, which covers the West Hertfordshire geography, which is essentially this end of the Hertfordshire patch, covering about 600,000 people. Part of the reason for mentioning that context is that place partnership then becomes a much more important kind of locus, if you will, of how health and care services are organised locally. And really importantly, it helps us to start organising services around communities and populations rather than individual service providers. So in terms of who we have around the table, that's a partnership that draws together local authority colleagues, general practitioners, our community mental health and acute services, as well as colleagues from the voluntary community and faith sectors. And the idea is that over time, that becomes, that group, that partnership becomes the main way in which we start to organise, commission and plan and deliver services for our local population. And we've started to break down the work into 4 neighbourhoods in line with national government policy, where you'll have heard lots of discussion about neighbourhood health nationally, or seen perhaps some of that in the news. One of those neighbourhoods inevitably is Dacorum. Then we brought together Watford and Three Rivers, which is the old locality structure, for those of you that remember the previous iterations of this. St Albans and Harpenden and Hertsmere are the 4. Each of those neighbourhoods are led by a local GP from within that patch, but also bringing together a team that comprises community services, a lead kind of operational manager, and increasingly, for example, secondary care consultants and a range of other staff are starting to be aligned to those neighbourhoods. So I thought useful context, hopefully, Chair, because I think that's framing some of our work locally, for example, on the health campus, which we'll come to, because that becomes a way, a kind of physical manifestation, if you will, of the work we're doing on developing neighbourhood health in each of our patches. I think that was all I wanted to say, just by way of update, I guess, from West Herts NHS Trust. If I pop that hat on briefly. As always, things are very busy at the hospital, but I'm pleased to report that we're continuing to make good progress on some of the things we know are really important to local residents. For example, A&E waiting times, where we've gone from being around 3 years ago, we were about 102nd nationally out of a league table of about 118 trusts in the country. We've now been in and around the top 10 nationally for the last 6 months or so, thanks to a huge amount of work, not just within the trust, as you'd imagine, but with lots of local partners. Similarly, we're one of the fastest improving providers in the region on elective care, partly because of the work we've done on urgent and emergency care, but making really good improvements in the amount of time people are waiting locally for access to planned care treatments. And we've now spent the last 6 months, we've hit all of the national cancer access targets, which is relatively unusual nationally. There's relatively few trusts that are delivering on all 3 of those things. So we're really pleased with that progress. There is loads more to do. Clearly, we don't get it right every time for everybody, and that's a huge amount of work that the teams are doing at the moment. But I thought hopefully a bit of context about what's happening. Okay, I'll pause there.
Okay. Does anyone want to ask any questions? Yeah.
Thank you. Rebuild of estate under the new hospitals programme. I understand certainly a few months ago the timescale was 2030, 2032. Is that still the case?
Very good question. So the short answer is yes, but can I give you a slightly longer answer to that question? Because I do think it's important to share as much as we're able. That is still the official timescale for the rebuild of Watford General Hospital. Having said that, we're very pleased that we've been supported by the new hospital programme, both to retain our programme team. The majority of other schemes that were not in what's called Wave 1, the kind of first tranche, have been asked to stand down essentially their teams. We've been enabled to retain ours. And the second thing is we received £12 million of funding this financial year for enabling works on the Watford site. I think this went out in a press release a couple of weeks back, but that's allowing us to progress with the next phase of the building works. On the Watford site, for example, we have a range of porter cabins down there which were previously used as inpatient facilities. We're really pleased to be rid of those. They were not good facilities to look after patients in, and we'll be removing those from site over the course of this year and completing a series of other key enabling work schemes this financial year. So the reason I mentioned that is we're continuing to work with the new hospital programme. We would like to bring forward that date, as you would imagine. That will depend on a whole range of moving parts, not necessarily locally, but in particular nationally. For example, how well the schemes are progressing that are ahead of us. So if any of them slip up, we'll be keen to see if we can move forward a bit.
Thank you.
please.
Yeah, giving many to completion. But the it's great to hear about the times at the A&E there. I did get the feeling that our urgent treatment centre has gone from the 2 hours, which we were promoting in order to encourage people not to go to the A&E in the first place if they didn't need to. But I've heard that's up to 5 hours at times. Good, I'm glad
You mean the urgent treatment centre
that.
here?
Eh?
You mean the urgent treatment
centre here in Hemel, yeah. Do you know what the response time is there?
If it would be okay with the committee, I'd be happy to dig out all of the trends on performance data at the local urgent treatment centre. As far as I'm aware, and our Chief Operating Officer will give you a much more thorough answer on this, we continue to have over 95% of patients at the local urgent treatment centre seen within 4 hours, and the waiting times continue to be pretty good. I think there have been the odd occasion where there's been huge influxes of people certain times of the week, along with, staffing shortages that have pushed the waiting times up, but it's been very much the exception rather than the rule. There's only been a handful of occasions I can think of over the last 2 years where that's happened, but I'm very happy to get the actual data and share it with you. It'd be more useful, I think.
Because you said 4 hours there, which is what the standard is, but it was being promoted as only being 2 hours.
Yeah, I think our average waiting time is still below 2 hours at Hemel, but let me triple check that for you.
Hasn't it been the case that actually it's Watford that have had worse figures?
Yeah,
UTC?
That's a really good point. In historic terms, yes, but also any hospital that has kind of admitting capacity, that has a majors in terms of an full emergency department, tends to have longer waiting times, often because patients take longer to be assessed and triaged and kind of put through the system in a major emergency department. So we have an urgent treatment centre at Watford as well, where we have, again, kind of pretty high performing service in terms of waiting times, but often it's the majors department that ups the overall average. But again, I can share all the breakdown and data if you would be interested.
Okay, does anyone else want to come in? Otherwise, move on. Are you able to cover the Integrated Care Board? Have you covered that, or are you happy to move on to item 4?
I'm happy to move on to item 4. I don't think there's anything else I'd add on the ICP.
All right. Catherine, I believe you're up next.
Thanks. Good evening. I am Catherine Silverton-Nari. I'm the Strategic Director for Corporate and Commercial Services at Decorum. I'm the joint project lead, officer project lead for plans for at Decorum for the new health campus. And Di can't be here today, so I'm taking her place in giving an update from Decorum's perspective. I'll kick off with a brief overview of the project and where we are. And you have to forgive me, the first time coming to this committee, you may know this already, but it's always useful to have a recap. And then I'll pass over to Toby and then to Sheena, our programme director, and to talk about the emerging clinical strategy and the engagement that's currently underway. So, right, let's move this onto slide. I'll stop sharing for a minute and share it again. Okay, so just kicking off, as I said, with a brief recap before I pass over to Toby. Overview of the project. There are 3 partners who are currently funding this stage, the strategic outline case of plans. So that's led by the West Herts Trust with the ICB, and then in partnership with the Decorum Borough Council as partner 2. The approach is aimed to be a holistic approach meeting future healthcare needs, including preventative care and support services, and looking at providing those range of services in a purpose-built and accessible central building. So this current stage is around exploring options which focus on local services, including, but not necessarily limited to, those provided at the Hillfield Road site to the health campus in a centrally accessible town centre location. And where we are now with that, so the feasibility study, which I hope you know took place back in 23 to 24, where a strategic case was established that led to the three partners agreeing to fund this current stage. We moved into strategic outline case. I don't know how much the committee has been told about this, and we don't want to get into probably more boring technical bits, but the business case development follows Treasury guidelines and has starts with a strategic outline case, then goes on to the outline business case for a full business case, which would include procurement. So we are currently in that first stage, which includes looking at the strategic requirements which drive the review of services and the development of a clinical strategy about what might be considered for inclusion, some high-level spatial planning as part of that, a cost review, options appraisal of various options, including funding and delivery models, and land as well, and critically the public engagement that feeds into that, and that's what Sheena will go through in a minute. And then at the end of the year, the plan is that stage, that case finishes, goes back to the partner organisations for approval, and once we have the required approvals, and that includes some central NHS approval hoops that have to be got through, the aim would be to move on to the outline business case where you really get into the nuts and bolts in 2026. So that's broadly where we are, and I'll now hand over to Toby to talk about the ambitions and the clinical model development.
So I may be preaching to the choir slightly on this first point, but I think it's really important if we're going to do this, we don't miss the opportunity. I think in particular, we can see the local demographics of Coram changing quite quickly at the moment. That's going to continue to change over the next 5, 10, 15 years. The health and care services required to look after local residents are going to continue to evolve, and we need to take the opportunity not just to do a simple lift and drop of existing ways of working and service models that we've got. So we want to use this as an opportunity to have a conversation with local residents about what those new services might look like and how we might continue to adapt what we do already, not least the kind of role of new technologies, but also shifting ways of bringing teams together to look after people rather than the fragmented model that people often experience at the moment. Obviously, great opportunity to have fit-for-purpose buildings. I think we spend quite a lot of time and energy and money at the moment maintaining the existing buildings in Hemel. We know those aren't fit for purpose, and so having a brand new facility really helps with that. And our clinical colleagues are very clear that just doing things differently on the NHS end of the spectrum isn't going to be sufficient. We've really got to think differently about prevention, and that's why I come back to the role of voluntary community, local faith sector, community leaders working with us on that prevention agenda, thinking about the role of early interventions and supporting people over the life course rather than waiting until people get sick. Bringing care closer to home, we've made some strides on that already. I was checking the stats just the other day. On any given day in Decorum, we have about a ward's worth of patients that we look after in our virtual hospital, which means that people don't have to travel into hospitals. We can look after people in their own homes. We'd like to at least double that over the course of the next couple of years. There's huge potential there to look after people where they're most comfortable, and lots of knock-on benefits that we've now got some really brilliant evidence around. And we need to coordinate more effectively urgent care. We discussed that earlier about the urgent treatment centre on the Hemel site. At the moment, it's not particularly coordinated with local general practice, and we know access to general practice varies considerably from one practice to another. We'd love to try and coordinate that more effectively and make it easier for people to see a clinician that can help them on the same day rather than have to wait or to travel significant differences. And we need to build flexibility into the model. If you really pushed me. I couldn't tell you what healthcare will look like in 20 years' time. I think it's hard to predict given the pace of change at the moment. And so making sure we have that flexibility built into the estate is going to be really important, because what we start with is not going to be what we finish with. I'll skip on to the next one, if that's all right. This is how we are starting to group some of the functions within the new campus. Lots of different ways of doing this, but this is one method that's reasonably tried and tested. We think important that we break out preventative care as something that needs to be a big feature of the space, and also a coordinating point for preventative activities across the local community. We know, for example, there's loads of evidence now that things like RSV vaccinations over the summer really help to reduce the amount of time that people spend in hospital over the winter, but we don't do enough of that, and we need to really do more reaching out into communities, not waiting for everybody to come to us. Our GPs are really passionate about the role of exercise, about dietary wellness advice. Trevor Fernandez would tell us all to stand on one leg as we're brushing our teeth. I'm sure he has. I think this increasingly will become a feature of how we work. Proactive and complex care, just to decode that slightly, that recognises that increasingly lots of people will be living locally with multiple conditions for a lot longer. And at the moment, the way we organise services means that people often spend a lot of time travelling between outpatient appointments, being subject to repeat diagnostics, telling their story multiple times. We need to get much better at that, and that means using multidisciplinary teams that draw together not just health professionals and experts, but also colleagues from social care, from voluntary sector services, to help to problem solve the issues that people have, rather than expect them to kind of follow the kind of breadcrumbs around the NHS, if you will. So we really want to bring that kind of multidisciplinary team element into this new facility and make sure that we're providing what's described here as wraparound support for people that have complex care needs, and also use it as a way of, as I was describing earlier, onboarding local patients into things like virtual hospital services that enables us to look after people at home rather than in a hospital bed. And then finally, I've talked a bit about same-day access to urgent care already. There are some brilliant kind of pockets of work in general practice urgent treatment centres. Community pharmacies in particular can be a brilliant, play a really brilliant role on this. They're not particularly integrated at the moment, and we'd like to look at opportunities for starting to draw that together within the context of the new facility, recognising we'll have an urgent treatment centre in there, but we need to make sure it's connected into all of the work happening in the local community around general practice and others. So that's just a bit of a flavour of some of the conversations that we're having with the clinical teams at the moment. I won't do a Wes Streeting impression at this point. I'm sure you'll have heard the 3 shifts. You will certainly hear a bit more about that over the next month. We're expecting the 10-year plan to be published probably at the beginning of July, around the anniversary of the NHS. That will say a lot more about these 3 things. We think we're really well placed locally to take advantage of that, not least because of the work I mentioned earlier with our Place partnership that started to bring together those senior decision makers across different bits of the NHS and the local authorities and the voluntary sector already. So I'll keep moving if that's okay. A couple of case studies. We think really important. We learned from what's working elsewhere, especially across the NHS. There are some really brilliant examples of community-based facilities that at least do some elements of the work that we'd like to do locally in Hemel. Washwood was on BBC News a couple of months back and got really good profile for some of the work it's done. There's a virtual tour of Washwood. If anyone wants to go on YouTube, we can send you the link round. It's described well here. We might even do a physical trip up there. We're just working on dates for doing that. We think it's a pretty good approximation of the type of thing that would work well in Hemel, mainly because it brings together these multidisciplinary teams under a single roof, and they're using kind of latest kind of data technologies to help to understand what are the day-to-day needs of the community that they're responsible for looking after, and how do they coordinate services for people in a way that works. So, for example, those teams have live data on who's pitching up at hospital, That means they can straight away get on the phone to the hospital and look at how they can get people home again. That probably sounds like common sense, but it's not a common feature of the way that the NHS works at the moment, and it seems to work pretty well. Skip to the next one. This says a bit more about Washwood, the care coordination centre I've just described, and some elements of this we've got pretty good work already underway. So we have.
Do you want to take questions as we go, or do you want to take it?
Oh, very happy to pause. Yeah. Do you want me to pause now?
Thanks.
Thank you, Chair. Thank you very much. I've actually got two questions. One of them will wait to the end. I do apologise, I'm a bit full of cold at the moment. This case study, what's it called? Washwood. Is this a case study to give us an idea of what to expect with regards to what's going on here?
So in the work to date, we have so far looked at about half a dozen different case studies around the NHS of community-based facilities that at least contain a significant overlap with the types of services that we think we might want to provide within the health campus. And Washwood's come to the fore as one that we think is really interesting. So that's why we brought it along today.
Okay, the reason I ask is case studies, great. Everybody wants to see success stories around the country, but how does that reference to us? I mean, what's the population it serves? What's the geography of the area? And what are you wanting us to compare something here with that or vice versa?
So at the moment, at this stage in the process, we think it's really important to be curious about how things work elsewhere in the NHS. These things will always have some stuff that's useful and some stuff that isn't. And we found that in every case study we've ever looked at. I think for this one, we're actually wanting to go and look so we can talk to the people. Often when you go and lift the bonnet and you speak to people, not all is quite as it seems in the YouTube tour or in the slide packs. So you really get into the nuts and bolts and the operational detail of some of these facilities to understand what works and what's transferable to our local context. So I completely agree, you've got to put kind of pinch of salt on some of the kind of shiny packaging around case studies, but it's also true there's often lots to learn.
Yeah, so it's not a pinch of salt. I just want to make sure we're comparing like for like. And if, for example, we see that, and then we're talking about, for example, the health hub, and the population's being served are totally different, and the environment's totally different, and so forth. I just want to be clear that it's a case study for a reason. This one's a case study for a reason, not because it's the first one that's been built or whatever.
Yeah, I think that's a really good challenge. My understanding is actually the demographics in this bit of Birmingham are really quite similar. There's some similar context in terms of the kind of local kind of town and some of the challenges that they've got from an economic perspective. But we're going to get into the weeds on this, so we'll perhaps bring back a next version of this once we've
I have got another question right from the beginning, but that can wait till the end. Sounds great. It just might be an idea to just hook up on that one point, because when we do come back, I think everybody around the table would be delighted to see something, as I said, that's working somewhere else and put it in context with Hemel Hempstead.
Yeah.
Thank you very much.
Thank you.
Okay, thank you.
So we were just going to talk next about the plan for engagement, which we kicked off over the last couple of weeks. I was going to pass to Sheena to do this bit, if that's okay.
Hello everybody, I'm Sheena Phillips. I'm the relatively new Programme Director for the Hemel Health Campus. I'm delighted to be here meeting you, and I look forward to engaging with you further in this. I'm really excited with this programme. I think there's such an amazing opportunity for Hemel, for Decorum, but also actually to really look at actually innovation in healthcare. And the Washwood example is an example of innovation, but actually what can we breed here that actually draws on the needs of the local population. And that's where engagement, to me, is so important. It's about actually what do you as a community want from a new facility like this, and actually what's meaningful to you as a community. So in May, we've done a lot of the data collection. So looking at, for instance, life expectancy from IMD, the wards from IMD 1 right through to 10. for men varies by 9.7 years, for women by 8.6 years. So you can already see that actually living in decorum is a very different experience from one group of people to another group of people, and actually hardware building services that are meaningful. And I have a lovely map of, it's a heat map of those deprivation areas. And then beside that is a heat map of our emergency admissions. And I'd probably love to show it to my children to draw little circles and spot the difference, because actually the relationship between the highest emergency admissions and deprivation is so close. And actually we really need to address that. And how does this building become a building that's not about walls, but actually about how we're working with the community? So this engagement work, I feel, is really, really important. So that data collection in May, we had a workshop in June, well, last week actually. So I really enjoyed that, and meeting lots of patients and having a really energized and interesting conversation. And what I felt going away, and I hope you did too, was an energy in the room and people behind this, and also that sense of not wanting to lose the opportunity of this program, that we really have to grab it and really make great sense of it. I think one of the feedback from that was we should involve community and mental health services more. So that was one that actually came up at another patient meeting I was in yesterday. So that's definitely one to take into the workshops we do into July and August. So alongside some more workshops, we're also going to host an exhibition downstairs here. I think we probably need to look at an exhibition actually on the Hemel Hospital site as well, for patients actually going into the hospital, but also for our staff too, so they're feeling, they understand, they know the story around this, and that's a big part of this as well, actually, is about this bringing the staff with us too, and they also are our ambassadors for this work we're doing. And then further engagement, I'll go to the next slide actually, just I'm talking this, it's also my colleague Nick actually, he leads this work with Kelvin and Louise, because this again is a 3 partnership piece of work. And so the event planning, promotional flyers, briefing facilitators, the information hub, and of course the online, and I've been on your website and actually looking at that and how well used it is. So how people, can we run a survey and do engagement online? Because what I realized from looking at the data is we need many different ways of actually engaging with people. It's not just one message and one route, but a kind of multimedia approach. Drawing all of that information then together and then pulling together a report that will help us with the business cycle of this, because we have to develop our strategic outline case, and we want to demonstrate the engagement and the level of commitment from the community to actually building this building into the future. So I'd like to say thank you actually for last week, because I felt really energized that people were with us and are actually coming on the way with us on this journey, and I thought it was a really good place to start.
Okay.
You're not going to say no, Sheena, you got that all wrong.
No, I'm not going to say that. You mentioned the ICBs and the clusters and the things we're going to put, the South and West Hertfordshire Health and Care Partnership, you mentioned it on there, is to some degrees going to be the commissioner. Yeah, they're going to be the commissioner. And West Herts Hospital Trust has a big, the host, whatever that turns out to mean. And we've got the Cornwall Borough Council here as well, Everybody's got to sign up to it in that respect. So it's more than just the green paper type of, it's not just health that are commissioning this, and not going to be commissioning everything else either. Any ideas? Is it going to work? How are we actually going to get people to do that and not have one person take over, I suppose, or nobody take over?
I just want to come in, Adrian. I'm very happy to. I'd like to answer that. I'd like to start answering that question. The whole point of all of this is that we've actually had a history of years and years and years of not getting very far with anything, with all due respect, and the way I see this project is that it is through decorum getting involved and taking an initiative, which we did take, which has created the momentum that we now have, as much as anything. I think we've had a fair wind because we've now got a new government, and the government are pushing really hard on the NHS reform and the 3 shifts from, I can't remember what they are, preventative to analog to digital, you know, the ones that you probably expect, most of them. I think one of them's a surprise.
Hospital to community, analog to digital, and sickness to prevention, I think is that.
Yeah. So it's the very fact that Decorum said, we have some land here, which there have been multiple attempts to redevelop and to regenerate that space in a completely different way. But again, Decorum had, since COVID, and ever increasing, like every town, like every big town, Hemel has a problem of getting footfall into the town. And we can support that by bringing people to the town centre to address their preventative health needs and their diagnostics and their proactive complex care. So to answer your question, the reason it's actually the reason there are 3 signatories to the memorandum of understanding, and there are 3 of us that have put money into the work that's happening to date, is because this is a project which is not just an NHS project. The Decorum doesn't have any locus on, and it's also got the ICB involved because that's a big source of going outside of what the trust knows about. So I view this as a very positive project. I fully recognise, because every time I talk to people, whether it's on the doorstep or whether it's online, there is a very simple answer to this, which is we don't want your health campus, we want a hospital. But I'm afraid my answer to that is, what is a hospital? I think most people would define a hospital as somewhere with an A&E. Hemel hasn't had an A&E since 2009. So I really question, I know it has the tag, I know it's called a hospital when you look on the map, when you look on Google, but I really question whether it has been a hospital for 20 years.
So thank you, but that wasn't quite my question. The question was more things like...
But your question was, how are the 3 people going to work together? And I've shown you that it was by the 3 people working together that we've got this far.
That's a little bit of my question. What it's about is things like health, community services. They're commissioned in a different way to what the ward is. The voluntary community faith and social enterprise sector is struggling for funds, for fundraising, and being commissioned by the local authority, by health. There's lots of commissioners in there, lots of money coming from different places. We want to make sure that it all joins up, because if it doesn't, then it won't, sort of thing. So it's bigger than what you're sort of alluding to. That is a part of it, I do agree, and that's specific here, but we need that to work wherever it goes. And those shifts require money, and they're talking now about moving proper money to the community, which they've never done in the past. They've saved money, but it's never really got to the community. But you, as the host, in some respects, but with all the other people, have got the choice, really, of whether you actually ensure that money does go to where it needs to go.
Yeah. And just to reply briefly on that, I've just come from our Health and Care Partnership Board this afternoon, and that's where we convene all of the partners around the table, and I think we have got to a point in terms of relationships between those different partner organisations, the kind of level of trust, where we kind of pride ourselves on being able to have high quality arguments about these things. Because it's tricky, there are finite resources, locally for 600,000 people, just for context. We spend in the NHS about £1.3 billion a year on health services. It might sound like a lot of money. It's staggering how much that's tricky and forces us to make decisions about priorities on a day-to-day basis. But we know that the best way of using those funds in the long term is to start to shift resource away from big hospitals and much more into the community. And we've started that process. We've now got dedicated secondary care consultants working alongside the neighbourhood teams I mentioned earlier. And we'll continue to shift resources in things like respiratory and diabetes and other specialties so that they're working alongside kind of general therapists and other community community services. But it will take time. But there is a huge amount of commitment from those partners to doing that. And usually, and I've worked in lots of different bits of the NHS, people are pretty much pointing in the same direction, which isn't a given. So I think it's still relatively early days, but I think there is a lot of shared commitment to that.
Okay, Lynn, you wanted to...
I did. Just a question on getting public engagement, which I agree is incredibly important. You've talked about having an exhibition in the forum and at the hospital. We have community centres, certainly within Hemel, and rather than expecting people to come into us, is there any possibility to add an exhibition roadshow so we can take that information out to the communities?
I think that's a really good idea, because there's something you're right about going out to people. I think I suppose my language really was not an expectation of people coming in. It's if they happen to come in, they see the messaging. And we want to do a multimedia and multi-type. And I agree, the roadshow, like the Hemel Health Campus on tour idea, I think is a really good one, and you can get a T-shirt if you. But no, but joking aside, I think that is really important, and certainly I'm joining the CLCH, for instance, there. Senior leaders meeting, HCT is a good one. I'm linking with Mary Hartley as well. I think that actually there is something about working with more with our community services too. So thank you, I'll take that back.
Edith, did you have your hand up?
Yeah, I did.
Okay,
Thank you. Two things. One, can we please have the slides? Because it's difficult to take it all in as a presentation, even though I had a presentation previously, but I never heard anything. So,
Of course, you're very welcome.
The acoustics.
I wear hearing aids, so I'm completely sympathising.
That's one. The other thing is, how far have you gone about establishing the needs of the population? And how can we all feed into that?
I mean, I can start a little on that. I mean, the ONS data, for instance, is showing that we're expecting growth. Well, actually, the 0 to 25-year-olds, we're actually going to have a population drop of about 800 between now and 2043. So that's actually a lot fewer younger people in the population. But alongside that, a growth of the over, I think it's 55s or 65s, I'll have to check the data, of nearly 14,000. So in terms of actually developing our services, and that's not to say that paediatric services and children's services are not important, and something I feel actually quite passionate about as well, but actually that frailty services and addressing the demands of an older, frailer population. And when I say that, I mean that actually our data shows that as you get older, you develop more conditions and more hospital visits for outpatients, for ED attendances, ED admissions. And we need to change the narrative around that and how we're strengthening how people age and age gracefully in a way that actually gives them a better health. And of course, I said about that variation in life expectancy earlier, and that's really quite challenging. We need to be speaking with communities where actually their life expectancy is shorter than other communities in Dacorum as well.
Just to add to that, so the team have done a load of work. It would be perhaps another, if I can add it to the list of things to share background with the committee. We can share some of the slides and some of the work that's happened to start to map out future health needs of the local population. And you can see in that data sources, I know you guys will have all sorts of comparators that you might be interested in. I think really important that we share that so you can kind of spend the time looking over it and check our working as well. It's really important we get that element right.
Okay, Fiona.
Thank you, Chair. Thank you to our speakers for updating us on the timescale for engagement. Are there any plans yet for the future of the Hillfield Road site?
So we are conducting an options appraisal. So that I think the simple answer is we know that we're doing an options appraisal, so we're looking at the options, and that goes into, we're working with PA Consulting, who are actually pulling together the data for us, and we're going from a long list then to a short list of what those options are. So looking at the Hillfield Road site, the Market Square site, or a variation of the two. We could have retain some capacity at Healthy Load, have Market Square. So, and there are other options as well. I think it's the Civic Centre as well. To look at, and that would all feed into the strategic outline case, and this then is submitted to the Treasury.
So, at risk of kind of repeating things that you may already know, there is no scenario in which we build a new facility on Market Square and close hospital services on the Hemel site before that opens. So we are retaining the services on Hemel for the foreseeable future until there is a credible alternative site within the Hemel vicinity that enables us to relocate those services. So I think we've talked to this group about exactly that point beforehand, but I just think it's helpful to clarify in that context. And of course, any conversations about the future of that site would be undertaken with exactly the same partnership. So that's very much a conversation with colleagues at Dacorum Borough Council and the ICP.
Okay, Alex, next.
Thanks, Chair. I'd just like to support Councillor Greenfield's point about using local resources, community centres and so forth, and social media. I think it's something that DVC doesn't take full advantage of, and obviously this is a really, really big issue, and the local resources we have cumulatively, I think, would be far more powerful than anything done here. My second point, Chair. Thank you. Could we go back to, I think it was the third slide? Can we do that? It had a list of stuff. Stuff. Oh, was that it?
The 3 boxes.
No, yeah, the next. No, not that one.
Is it about?
Before that, I think, wasn't it?
Is it about where we are now?
Yes, this is it. Okay. This is it. So the cost review is before the land review and valuation. So we're going to cost this, and then we're going to find out how much the land is going to.
No, Alex, they're not numbered.
No, I know they're not numbered, but I'm just saying it says cost review, and then it says land review and valuation.
Yeah.
I think that's
Should we? Is it helpful to decode a bit what that relates to?
Well, one, you know, I'm assuming they're done in some sort of sequence. Okay.
All done in parallel. I mean,
that's fine.
All of this is being done in parallel at the moment. That's the general
Just
thing.
want some clarification.
Just going to bring Jan Madden in, but I just want to say, I think then can we keep going with the presentation to get to the end of it and then take questions then, unless it's really contextual at the time.
I think we were pretty much there with the presentation, by the way, Chair.
Okay.
That was the last slide.
Well, we'll do Jan, then we'll have a general discussion. Jan.
Okay, well, I've got a little list of questions, but I don't want to hog everything, but they are important to me. So, first of all, when you're saying about assessing the need, you've done this need assessment, how many people, and blah, blah, blah. How much weight is given to the 11,000 plus new homes that we're going to be having in Hemel Hempstead? Do you want me to ask all of these, and because they kind of, some of them wrap up together. So that's the first one. The numbers that you said about the reduction in the expected younger people of 800 and something, does that include the people that are going to be housed in Hemel from St Albans District Council? So looking at their local plan, their biggest portion of their building is coming here, which means most of their social housing, affordable housing, etc., presumably will be here as well. I will be able to tell you that definitely later in the year because I'm doing a dissertation on it. Are you still looking at a 5-storey building, and are you yet sure, if so, what's going in it yet? And the reason I'm asking this is because I had quite a heated discussion with Trevor about this when he said, we're building a 5-storey building and we don't yet know what's going in it. And I said, no business, no commercial business would work that way round. They would always look at what do we need to put in it, what services are going in it, and therefore how big do we need it. And he got quite shouty with me for challenging him on that. He said I was entitled to my opinion, but basically I was wrong. So that, I'd like to know if you've thought any more about that. That was it, that was all of them.
Isn't the first bit of, sorry, no, the first, I think it's helpful, the first bit of feasibility work that we did in 23-24, I think is where the 5 stories came from.
I think that is the case. There's a reason why Trevor's now charging the money. It's a very, very good GP though. I think, as you say, the exact space requirements for the building are entirely dependent on our assessment of local population need and the range of services that we are going to locate in the building. That's how we construct what's called the schedule of accommodation.
Forward plan local.
Exactly. And so all of your other questions are related to the question about the number of stories of the building, I think, as you'd realised. I think the question on the 11,000 new homes is a really good one. We've had challenge from colleagues already on exactly that point, and we're looking at all the different data sets at the moment, working with colleagues at the Cornwall Borough Council, with public health leads that are very expert at this, to try and work out what's the best data to be using to help us understand not just the kind of size of the population, but the likely demographics of those new homes, which has a big bearing on things like healthcare facilities. I haven't clocked the bit around St Albans and social housing, so that's really interesting. Please do let us know if you're doing further work on that, and we'll certainly pick it up with colleagues in St Albans as well.
Well, I'm going to be interviewing officers and councillors.
Yeah, please do share your work with us.
And that's part of the Hemel Gardens community.
Yeah. And just to add to that, just to manage expectations of where we get to at the end of this stage, we get to a high level of understanding of what services and a schedule of accommodation, what that footprint might be. But the outline business case will really develop that even more. So it's not that by December we'll have it all done and dusted and know exactly where everything's going to be and where all the stories are, but we'll certainly have a clear outline of what services and that footprint.
It's all a much more sensible response than I had last time.
Okay, is there any more to do on the presentation?
That was the...
No, that was it.
Okay. Does anyone else wish to discuss the presentation or make any points about the presentation as a whole? Well, you've asked everything you want to do, so. Okay, I think we've covered it all then. Thank you very much for that. I think it's most enlightening, and I look forward to its progression in the next few months. Okay.
Thank you very much.
We'll come back to the next committee with a further update as well. Yeah.
Is there anything further from the public wishing to raise? I've not been mentioned a bit earlier.
I don't.
Okay. We've lost all our officers.
Yeah. That's okay. I mean, I don't think we get a direct opportunity as you're giving us, but now that you've done, I'm going to say is that the you know, we need people who need to be treated now, and we need the sort of services that they're sort of proposing up here on the wall now, and I believe we can deliver a lot of that now, and that's what I would like to encourage as a committee to say, prove you can do it, and yeah, we'll have it on a new building very shortly. Prove us that you can actually deliver that sort of model of care anyway. And they should be. Well, I've been talking about this for years now, that you're proposing these new models of care. I see no reason why they cannot be implemented now. Let's have them and prove the cases. So that's outside them being here, sitting here, because they're not going to say yes or no to that. But I think that's what we need to push for. integrated neighbourhood teams have been talked about for about 18 months now. They've changed that. I haven't seen anything delivered yet on that.
Care closer to
Well, there's two models of care close to home. There's the one where we're having eye surgery up in Highfield, or eye tests up in Highfield, which is good for Dad. He could almost walk there, but we have to give him a lift to that. But for someone else, it's 3 buses. We look quite often, and now it's the closer to home for hospital services, but we're not talking about hospital services by the sound of it. But it really is about, we need to push that we get the services we need today as well as in 10 years' time.
Would any of the, Adrian, do you have any things to comment on that? Or do we note it? We note it, okay. All right, I will move on. Now, the request by Pete Hemel to put Bennetts End Surgery Car Park on the agenda.
It's not a car park.
Pardon?
It's not a car park.
Yeah.
Sorry. Okay, Lynn, are you
I am.
able to say?
It may not technically be a car park, it is used as a car park.
Yes.
So I'm sure we can make the language that way round if you would like. For those of you who have been to Bennetts End Surgery and have had to use that car park, you know that is probably one of the biggest health hazards in Bennetts End. And one of our concerns is that, you know, it's nice and warm now, but as we go into the winter, that becomes an even bigger health hazard because the potholes freeze. Some of the older, unwell and more infirm patients are at a higher risk of falling. And as you know, the funding needs to be made available to facilitate the conversion of that old tennis court, which is used as a car park, into a safe car park facility. We know that the staff currently do their best to park behind the building on the tennis court, which is used as a car park. Do I have to keep saying this, Adrian, or can I just call it a car park?
We'll take it as read.
Okay, thank you. So they try and facilitate making the spaces in front of the surgery available for patients. However, that isn't always possible. And that's become more difficult as things like social prescribing have been moved to the Bennetts End Surgery. And that obviously starts to deliver some of the things we were talking about there in terms of prevention rather than treating the sickness. But as Kevin was saying, we need the facilities and the support to do that. We believe there may be a solution to the funding of the lift and relay of a proper car park at Bennetts End Surgery. But just in case there is an issue, we would like to ask for support from the committee to ensure that that car park becomes a safe area to park that allows patients to access the surgery.
Okay, Alex, do you want to come in?
Yeah, I've got a lot of empathy, but at the same time, I would like some clarification. So it's a car park, but it's not a car park. I get it. But the thing is, if we're going to commit our support, don't you think it would be an idea to tell the committee who the land belongs to?
Decorum.
It is Decorum land.
Absolutely.
That's my understanding, yeah.
It is Decorum, 100% definitely Decorum.
All right, so I have got some options, but I just wanted some clarification on that. So Decorum allows it to be used as a car park, effectively. But I don't want to have this. Sorry?
I think there's a sign up.
Yeah. I haven't got that.
Everybody uses it as a car park.
Can we have one at a time, please? I'm going to come to Jan if you're finished, Alex.
Thank you.
First of all, I'd like to declare an interest in that. Pete and I, even before Lynn became the borough councillor, Pete and I were working on this last year. You can call it whatever you like. I've lived in Nash Mills for 27 years, and that has been a car park for 27 years. Nobody ever said it wasn't a car park until somebody started asking questions about 2 years ago about the state of it. It is a car park. The sign went up because we started raising issues about the state of it and how dangerous it is. And so they've put a sign up saying don't use it. They were actually going to cone it off at one point, which would be ridiculous. I've done surveys online. I've got the results of the surveys online of all the people that use it, that say, some people say that they can't use, they used to use it, they don't use it anymore. So now they park in the shops because they don't feel safe to walk across it. So what that's doing is clogging up the shops car park, and that's putting pressure on that car park, which means people don't go to those shops. So they go somewhere else. It's causing havoc. We have got to find a solution. We have got to get that car park serviced. And it is not a tennis court, it is a car park. It might have been a tennis court. You know when you adopt a piece of land and you look after it or you use it for 4 years as a private residence, it becomes your land. If you do that, if you have something commercial that you're using for 10 years in a certain way, it becomes accepted that that is what it is. 27 years that I know of, that has been a car park. That's my piece.
Yeah, okay.
Yes. Yeah. So why doesn't DBC just sell it to the NHS then?
Because it's not only for the it's not only for the surgery, Alex. The whole of Coronation Fields. No, I'm just saying. No, I'm just telling you. The whole of Coronation Fields, which is it's at the back of the surgery, and it's the whole of Coronation Fields. It's the only parking for Coronation Fields, where there are all sorts of things. They're already done some work there to improve the things. There's tennis courts have been done up there that the local residents all use. Now, local residents who live in my road are not going to walk up there because it's a mile uphill all the way. And so what they do, they drive up there and they park in there to go and play tennis and do things like that. So it's not just for it is not the surgery car park. The surgery car park's at the front. It's a different part, around the other side of the building. And the surgery accept that that's their car park. And in order for people to use the DBC bit at the back, they have to drive through the surgery car park. So we should be quite grateful that surgery do look after the bit at the front. So there we are.
Adrian, do you want to come in?
Yeah. So I think, did you say 27 years or something that the car park? There you go, a Freudian slip.
There you go. Well done. You've accepted it's a car park at last.
The place that people have been using as a car park has been acknowledged to be falling apart for 27 years. And I acknowledge that it's not just a surgery space, but it is used by the surgery. Yeah. And I'm really, the last I heard, the surgery are not engaging with DBC about how to make this space into a car park. And I find that really surprising.
What do you mean? What?
Because somehow there's got to be a financial model, first of all, to turn that into a proper car park.
Okay.
And then there's got to be a model for what happens when it breaks down in the future. And how
Coming back on that then, using your theory there, we've got an issue with the Memorial Garden in Nash Mills, which is owned by a private developer. Coram won't look after it because it's owned by the private developer, and they will never take on the maintenance of it because it's owned by a private developer. Why should the surgery pay for that when it's owned by Decorum?
Can I raise a point? I'm not convinced this is a question of a health matter.
That's what I'm thinking.
And I think it's a valid issue to do with parking in Decorum, of which there are a lot of issues that people raise. But I would honestly, I'm inclined to suggest we ask that this be referred back to the portfolio holder responsible for parking and to come up with a proposal. Sally, do you want to come in?
I'll let you finish and then I'd like to say
Okay, but I really feel that it's not, I would like some clarity as to whether it really is a matter of health before we can continue to discuss it in this committee. Sally.
Yeah,
Thank you for letting me speak, Nigel. This matter was discussed at the Strategic Planning and Environment Committee meeting. There is a report, a publicly available report on it. In that report, it says, it identifies the resurfacing, this is 4.2 for those of you that want to find it, for resurfacing of the old tennis courts to create a car park. It is identified in this report on the Coronation Fields. Later on down, it talks about the funded bits and the unfunded bits of Coronation Fields. It requests 4.5, 117,000 of the phase 1 project deliverables remain unfunded, including the resurfacing of the old tennis courts to create a car park is partially funded, and it's in the table above. There is a request that these elements are funded from a supplementary capital budget request as part of the ongoing capital budget review. This is in the agreed papers that went through scrutiny. Next steps and conclusions, that support is given for the section 106 funding identified in paragraph 4.2 to be used for the relevant phase 1 deliverables. This matter has been discussed at strategic planning and it has already been agreed. So I'm not sure, I agree with you, Nigel, I'm not sure why it's come back to this committee.
Right, I'm basically going to close this point down because I think you've had a chance to raise it. It's noted, but the other committee is dealing with it in the appropriate manner. So thank you for that. Are there any other, well, I haven't been notified of previous issues. So Fiona.
Heart surgery, Warner's End, it does have issues over and above the pressures that face all GP surgeries, but I have been informed they are in the process of recruiting a new practice manager.
Practice manager. They're going to get a new practice manager.
Okay.
Moving on to that.
Is that,
Can I add to that from Councillor Mitchell, who wasn't able to be here tonight but wanted to be? I'm sure shares the feedback of Councillor Guest that the performance of the surgery has deteriorated considerably over the years. It's difficult to get appointments in a lot of surgeries. It's almost impossible in that one. There has been a loss of staff and as a result patients are having to look elsewhere. So it needs to be acted on urgently to improve patient confidence in the provision of healthcare.
okay.
Can I say something?
Yeah, please do.
It's about Warner's End and that huge development, which they couldn't find staff for either, which is another problem there. What was I going to say? Oh, that's right. What people are doing now is the little chemist in Boxmoor. They're all going in to the chemist instead of the doctor. I was there this morning. There were 3 people queuing up to see the pharmacist. So that's a state of play, which is quite shocking.
Chairman, if I may,
Fiona.
thank you, if I may to be here, but in January 2024, the government introduced the 24. Anyway, it was 23. The government introduced the 24. The government introduced a scheme called Pharmacy First, where patients could get antibiotics for 6 common conditions, not life-threatening, not serious, but doing antibiotics from a pharmacist, from a community pharmacist, without having to see a doctor. It's called Pharmacy First. And this is an extension of the pharmacist role. Pharmacists using the training that we're trained to do, because we're trained to do far more than count tablets. And it sounds like that the pharmacy in Boxmoor, that people are aware of Pharmacy First and have embraced Pharmacy First.
What I'm not sure is to what extent this committee has the power to intervene on the ward issues to do with the performance of that pharmacy, of that surgery. Please, Fiona.
Thank you, Chairman. I suspect it's out of the scope of this committee, but I was updating on the committee on the situation, which is something that, as a ward councillor, I've got my finger on the pulse on.
Okay. Alex?
Is there something we can take to the NHS next time they're in?
I would have thought so if they were here.
Because when the ward issues used to come in, I think instead of just noting, we had this idea of presenting them to the NHS representatives at the next meeting when they were here, because with all due respect, noting things doesn't get things done.
No.
And we need, I mean, that's really bad if a surgery is like that. And I get it, we're a scrutiny committee, so we haven't got any powers to do anything, but there must be some recourse, there must be some channel through which we can direct all this stuff. And if the NHS guys are here,
I think there should be a method of how do we raise this as a complaint.
I've got the leader of the council here, we've got supporting officers here.
Is it the responsibility?
There's got to be a mechanism. I mean, that's a big deal.
The ICB is.
Yeah.
CQC.
Yeah, and I think just to put on the agenda for next time, Chair, myself, it's something that we should put to the NHS people when they're here. Can we give them those issues? Because residents need to know that, you know, at least something's happening. You're the ward councillor, Fiona, which is great, and you've reported it, but are we just going to say noted? Of course we're not. We'll have to do something.
I think the question to me is, what is the method of escalation for effectively complaints about the NHS, the way it is organised, and how does anyone pursue those to make sure that they are properly taken forward and resolved?
Chair, I totally agree. In this case, it's quite specific. But I've been complaining about the NHS since I've been on this committee.
Well, I'm expecting it has been. But if we to just give a representative a grilling, to me, you need to actually present to them
Hopefully
in
they can
advance.
help.
But I'm going to come round to people. First of all, Jan, then Fiona.
Can I suggest that I think going back over the years, I've sat on this committee for 10 years, and going back over the years, if something like this came up, if I remember rightly, the chair would write on behalf of the committee to, in something like this, I would suggest the ICB to say that this has been brought up at this committee, and can they look into it and report back to us what they're going to do about it? And surely that is within the remit of this committee to do that.
Yeah, that's right. But Chair, if you may, we used to do that. You're absolutely right, Jan. I remember that. But again, nothing. I've got no record. Stuff just got noted, and letters just went out. There were loads of times when we would have, follow up from minutes and correspondence. There wasn't any, nothing would get done. And I think if we have a formal meeting and there are representatives from the NHS, not to give them a grilling, I don't mean that at all, but to make them aware of situations like what's going on there.
Yeah. Is this related to the first point?
Yeah, it's related to this. So, this health services are held to account in Hertfordshire at Hertfordshire County Council. We are unusual in this borough, in this district, in having a health committee. It's not a statutory committee. I would suggest that if we are looking to do things through the proper channels, we probably should also think about, at the very least, doing it through both. So yes, do it locally, but do it through the statutory channel, and that's bound to be belts and braces.
Agreed.
Yeah. Okay. Fiona.
Thank you. It used to be the case there would be NHS England that would deal with a complaint about a GP surgery, but I do believe these days that the ICBs, the integrated care boards, do have a role. So the ICB would be the people to approach. And on a wider scale, see, last year someone contacted me about variation in GP surgeries across Hemel. I got it put on the Hertfordshire County Council Health Scrutiny Committee, of which I was a member at the time, that if it could be scrutinised variation in GP practice across the county. It's been put on the agenda on several occasions, but the NHS have pulled out and it's been deferred to a future meeting. And as a result of the County Council election results, I'm no longer on the Hertfordshire Health Scrutiny Committee, so I'm not able to take part in that now. But I don't know what's happening, but it was put on the County Health Scrutiny Committee agenda, but deferred and deferred and deferred.
Okay, Jan had your hand up first, then Alex.
Just on Adrian's point, I still believe that the direction is ICB and not the health scrutiny at county. Simply because I also used to sit on health scrutiny at county. They don't, unless they've changed, they might have changed because I haven't attended a meeting for a long time, but they were never that specific about a particular surgery. It was more strategic, the stuff that they did at health scrutiny at county level. If we have a problem with a surgery in our patch, I think we should be going to the ICB. I really do. But if you want to send it to both, then that's fine. But I'm not sure what health scrutiny at county would do with it, to be honest.
Okay. All right, Fiona.
Thank you. Following on from what Jan said, health scrutiny county does deal with things on a strategic basis, and they specifically, certainly a previous chairman that used to specifically say we can't deal with specific cases based outside the meeting.
Yeah.
So health scrutiny wouldn't be able to deal with Hertford Driver's specific case. But what I got put on the agenda was variation in GP practices across Hertfordshire, which at the request of the NHS kept getting deferred and deferred and deferred.
Okay, Kathy, do you want to?
Yeah, so I do believe that previously David Taylor did write to the ICB about some issues around Parkwood Drive. So they are the right body to go to because they monitor the quality of services that they commission, which includes GP surgeries. Absolutely.
I mean, I would have said that it is more his area to take up individual cases and ours to take up the general provision of service. But that's a comment, Alex.
Is there somebody on this committee who's on the Herts Health Scrutiny Committee?
Sally?
Decorum has nominated Brian Patterson to be on the health. Decorum Borough Council has nominated Brian Patterson, Councillor Brian Patterson, to be the Decorum Borough Council representative on the Health Scrutiny Committee.
Does Decorum not have a county councillor though? We always used to have a county councillor and a borough councillor, each of the 10 districts.
I haven't been asked to nominate a county councillor. I was asked to nominate a borough councillor. I can go back and ask.
Okay. It used to be that there were 10 county councillors, 10 borough councillors, and not the borough councillors were definitely one from each district, but the county councillors tended to be, and I'm sure Fiona will remember this, one from each district as well. What was that?
Each borough.
Can we, Fiona?
Each borough and district or district across the county has got a borough or district representative. The county councillors, they're not on a spread of one from each borough.
Okay, well, they kind of were when I was
Okay,
on, but there
can we?
might have been luck. Okay.
Right.
Moving forward, Chair.
Yeah.
With respect, I think passing it on to the MP, I don't think I don't think that's going to work, and I think it might be an idea, again, talking to the NHS when they're here, to ask them what would be the best way to take this on. I totally agree that going to Hertfordshire, while we might CC in any correspondence to Hertfordshire Health Scrutiny Committee, I've been on that committee, and all due respect, I haven't got much confidence in them getting stuff like this done at this level. And we can't let decorum residents suffer because we aren't able to direct a communication somewhere. And I think that this should be on the agenda for the next meeting when we've got NHS here. If we can't come up with a solution in 10, 15 minutes, then I'm afraid it means we surely need to talk to somebody else. That's logical.
And you think they should know beforehand?
Yeah.
Yeah, I mean, it is a case of giving them notification.
They might just come up and say, oh yeah, you need to do this. I don't think they will, but I'm just saying we're going around in circles now.
Okay, I think we've taken this as far as we can. And I think it is a case of it needs to be raised with them, but it's also making sure that they're willing to come along with an answer to that. Okay. Now, covering that, we've covered 8 and 9 already. The County Council Health Scrutiny Committee report and the adult care reports, I'm not sure that I've actually seen them. No. So I believe in the past that had just been left. And then for the work programme, I didn't see any documents with a existing work programme. But I do note the requests that we've just discussed for a discussion about how complaints are handled with the NHS.
Chair,
yeah.
If you don't mind, yes, that's only one issue, but I think that that will be quite a big discussion. And I think if we can establish a mechanism to get complaints and issues looked into, if not resolved, I think that would be well worth just having one item, to be honest.
I think it's a question of finding out how
Indeed.
we have to
Yes, I
handle
agree, yeah.
that in a way to achieve an outcome from a meeting, rather than try and work that out now. Okay. Is there anything else people wish to raise in the work programme? Fiona.
Thank you, Chair. I'm going to step back in the conversation with the County Health Scrutiny report and the Adult Care Services report. When I used to sit on this committee, was when I was at one stage I used to produce the written health scrutiny report, and then Bob Beecham, who used to represent Hemel Town, when he became the quorum rep of the County Health Scrutiny Committee, he used to produce either a written or a verbal report. And I used to produce, I sat on the Adult Care Cabinet panel at County, I used to produce a written report for this committee. Is that something that is normally done?
It's always in our face.
I mean, I'm new to this role, so I can't really comment as to whether it has or has not been done.
Chair.
Just a moment. Cathy, do you want to?
Yes, so just to clarify, I think there was a point where we'd asked that the health scrutiny rep attend this meeting and give a verbal update, but for a variety of reasons that didn't happen. And again, the same with adult care services, whoever was representing attending adult care services to give a verbal update at this meeting. I'm not sure if you're...
Okay, I think it's a case of considering how that is done for the work programme. Jan, do you want to come in?
Yes, just on that as well. Many years ago, I was elected by this committee as the deputy for the borough representative. And so if the borough representative, when it was Alex, for instance, couldn't be at the health scrutiny at the Hertfordshire committee, I would go as the substitute, and that's a sort of an agreed thing with Hertfordshire County Council. That's never been changed, so until it does get changed, I guess I'm still the sub. I was going to ask something on that. Oh yeah, can I just ask Sally on it is on this, just relevant to this. You say that you've nominated Brian, but he's not on this committee.
No, he's not.
That just seems like a really unusual thing to do. It's always been that the Hertfordshire Scrutiny, Health Scrutiny Committee's decorum representative also has always been on this committee. Because otherwise there's no communication between the two roles. It seems really strange.
Sally, do you want to respond?
I needed to find somebody who was happy to do it, and he was on this committee, but I think he stepped down from this committee because for various reasons, but he's happy to do it at the county level.
So there will be no connection between what's discussed there and what's discussed here. That just seems very odd. We don't have a county councillor or a borough councillor now who's on this committee and on the health scrutiny. It just doesn't seem appropriate, really. But
Alex,
thank you. Jan, wasn't it a case of somebody at HCC would send the relevant minutes to somebody at DBC, and then they would be included with the minutes for the meetings? But there was this phase discrepancy. The minutes for adult care services and from Herts health scrutiny would always lag or precede, depending on which way you looked at it, the DBC health scrutiny meetings.
I think we've discussed this point at length. I think it's a case of let's go away and think how best these reports are brought back to the committee for discussion, and it's also partly what we actually wish to achieve with those reports. But I think we're not going to actually solve the problem tonight otherwise, because it's a case of considering who is representing us in different ways at different committee levels. So
have you got action points from this discussion then to take away?
That's what I'm proposing, is we look at actually how those reports are covered and brought back in future.
Okay, but not with specific questions to go away and answer and find out. Okay.
So if I put on the action plan, the chair and the committee members to come up with ideas of how the reports need to be brought back to the committee, then maybe you can feedback in the table of the action plan if you've got any comments of how you think they need to be brought back.
And will that be done, that's something that you want us to do like imminently?
Well, I will send out the action plan and then you just put it on once you've thought of the ideas and send it back to us.
Thank you. Thank you, Ken.
Okay, what do you suggest?
Well, I think it's quite simple. I think we just contact HCC and just ask for copies of the minutes to be sent to us.
They are available online.
Yeah, so
it's just a case of distributing a link to
which minutes are available online?
Well, the minutes of their health scrutiny meeting.
Health scrutiny.
I think
and all the meeting minutes will be online as ours.
I think the point that needs to be made is, are we going to look through loads of our minutes and then loads of their minutes? Somebody has to go through and tick the relevant bits for decorum.
I don't want to give, I think we want to take that away considering how it is best addressed. Okay. Because I do not think we can solve the problem in this meeting.
Indeed.
We might choose to discuss it in a future meeting, but until we actually consider it, can't say. And there's also a question of exactly how it works. And without actually having looked at the health scrutiny minutes to see to what extent they're strategic or particularly applied to decorum, I don't think I'm able to contribute to that. So we do want to put things on the agenda so people can come into these meetings on an informed basis. So I think that is enough on that point, and we'll close that down. So, and as that's the last thing on the agenda, I'd like to thank you all for attending and close the meeting.